A 34-year-old Caucasian woman, gravida 1, para 0, presented to our hospital with repeated attacks of mild vaginal bleeding. Our patient, according to her sure reliable dates, was 16 weeks and 3 days pregnant. She had a history of primary infertility for 7 years preceding this pregnancy, and she had sought medical advice for delayed conception 1 year after marriage. Male factor infertility was excluded by a single semen analysis, and she was informed that her hysterosalpingography was quite normal. She was given medical treatment that she could not recall to improve her cycles. These were infrequent and irregular over the last 5 years. She used these medications for about 4 months, after which she reported some improvement in her cycles, but conception did not occur. A hormonal profile was ordered, and our patient was examined transvaginally by ultrasound. Subsequently, she was informed she had bilateral polycystic ovarian syndrome. Her physician prescribed clomiphene citrate, Clomid, Global Nappy Egypt, 100 milligrams for 5 days, beginning on the 2nd day of her cycle. Our patient continued taking the drug without ovulation monitoring, and the regimen was repeated with an increasing dose up to 200 milligrams daily for 6 successive months. Laparoscopic ovarian drilling was performed, and our patient resumed using clomiphene citrate 3 months after the operation without prescription. 2 months prior to admission, she took 250 milligrams of clomiphene citrate, 5 tablets per day, beginning from the 2nd day onwards until the 13th day of the cycle. Our patient had a missed period immediately after this haphazard regimen. Pregnancy was confirmed by a urine pregnancy test, then by a transvaginal ultrasonographic examination that was carried out 6 weeks and 3 days apart from her last menstrual period. According to this ultrasound report, the gestational sac corresponded to the 7 weeks of gestation. However, there was no comment regarding the presence of thica-lutein ovarian cysts. She did not follow up with her pregnancy until she reached the 16th week of gestation. At that time, she experienced recurrent attacks of vaginal bleeding that she described as mild and dark-colored. Apart from pallor and tachycardia, our patient appeared quite normal on general examination. Her pulse was 106 beats per minute, blood pressure was 125/85, and her temperature was 37.2 degrees Celsius. Abdominally, her uterine fundal level was equivalent to 28 weeks, and the uterus was dewy in consistency in most of its mass. A transabdominal ultrasound examination revealed a huge, complete Hydatidiform mole occupying the lower pole of the uterus, and a coexisting fetus with its placenta that was enclosed within a separate sac, shown in Figure 1. Our patient was admitted to our hospital, and full laboratory investigations were ordered. Her blood test results revealed microcytic hypochromic anemia, and her hemoglobin level was 9.6 grams per deciliter. Other investigations were normal. In spite of her testing positive, her serum beta-human chorionic gonadotropin level was relatively low for a patient with complete molar pregnancy, 8,354 milli-international units per milliliter and 7,799 milli-international units per milliliter in 2 serum samples drawn 2 days apart. The technician did not suspect any technical error, and he confirmed the accuracy of the result. However, he considered the possibility of falsely low results, and accordingly a senior specialist was consulted. She repeated the test with serial dilutions, and beta-human chorionic gonadotropin was found to be 1.876 million milli-international units per milliliter. Our patient was counseled about the risk of continuation of this pregnancy and the low possibility of fetal survival. However, our patient refused intervention and insisted on conservation. Prognosis: complete Hydatidiform mole.